gathered here to discuss about maternal sepsis. Pata bhi nahi chalta and it kills silently. So coming to the definition, according to WHO 2017, it is a life-threatening medical emergency defined as organ dysfunction resulting from infection during pregnancy, post-childbirth, post-abortion, and postpartum period. It was seen that every year 295,000 women die due to complications of pregnancy and childbirth, and especially in no middle income countries. And the main causes of maternal death are postpartum hemorrhage, preeclampsia, and sepsis. That means sepsis is the third commonest cause of maternal mortality. And my mission of life as an obstetrician, which I'm sharing with you all, is ending preventable maternal mortality. I exclusively work in obstetrics, and our mission of DGF is zero death due to sepsis. So this is one step forward for that. So sepsis is the third commonest cause of maternal death in India and in the world. Unfortunately, in spite of having so many antibiotics and supportive management, the incidence is rising even in Western countries. It can kill. So by taking early action, we have to save lives, like practice clean care, diagnose early, and treat promptly. Every 4 minutes, a woman dies from sepsis-related cause somewhere in the world, with the greatest burden borne by the low and middle income countries. Even if the patient survives, there is long-term morbidity, many chances of neonatal sepsis, preterm birth, admission of the baby to NICU, and increased perinatal mortality rate. So it is a highly lethal condition, and without prompt recognition and appropriate treatment, it can quickly lead to death. And it is rapidly progressive in nature, but challenging to treat. So we are the obstetricians of Delhi, और मैं हमेशा एक बात कहती हूँ कि we take this as an opportunity to test our clinical acumen. Let's take the challenge. Let's treat and prevent maternal sepsis and show your expertise. So we will discuss about evidence-based management of maternal sepsis, which is now an evolving challenge for us. When we talk about causes of sepsis, then most of the causes are obstetric causes like septic abortion, chorioamnitis, endometritis, postpartum period, wound infection. Non-obstetrical causes are UTI, pneumonia, appendicitis, and a few gastrointestinal conditions. Assisted reproductive technique cause little more sepsis and multiple gestation because of multiple maneuvers. So basically, why have I shown you this picture? This means that sepsis can involve any part of the body, here, 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 everywhere. And sometimes first it begins with a single organ dysfunction and then it leads to multiple organ dysfunction, which may be cardiovascular, hepatic, gastrointestinal, hematological, endocrinological, central nervous system, all. Among the causes of maternal sepsis, 40% are caused by genitourinary infection. So whenever we are suspecting sepsis, first we have to rule out the genitourinary causes of sepsis. And among the genitourinary causes of sepsis, Escherichia coli is a major contributor. Then we have Staphylococcus and Streptococcus. It is notoriously known as gas, Group A Streptococcus pyogenes. Besides, other organisms are Streptococcus pneumoniae, and the most problematic is MRSA, methicillin-resistant S. aureus. Till now, we used not to talk much about MRSA, but when we deal with sepsis, we have to be acquainted with this term, methicillin-resistant S. aureus. It's a very common cause of sepsis in the post-childbirth period. Now, when will you suspect sepsis? The patient must be having some signs and symptoms. Patient can have fever, rigors, diarrhea or vomiting. They are indicative of early endotoxic shock. Then rash, abdominal and pelvic pain, tenderness, Offensive vaginal discharge is a very, very important guide. Smelly suggests anaerobes and serosanguinous suggests streptococcal infection. Then projective cough suggestive of some lung problem, urinary symptoms. In fact, urinary symptoms are a very common cause of maternal sepsis. And these are the red flag signs and symptoms that should prompt urgent referral for hospital assessment signs. Once you suspect sepsis, the patient requires a hospital treatment, not a nursing home treatment. So when there is pyrexia of more than 100.4 degree or less than 96, this means patient has already gone into hypothermic shock. Then sustained tachycardia more than 90, few books say 100, you take it between 90 to 100. Then breathlessness, any respiratory rate more than 20, abdominal pain, chest pain. And one very important clue is a woman who has been given all sorts of treatment in the postpartum period, still she is saying, I am not well, she is feeling anxious, she is looking distressed, and she is generally unwell. Please rule out sepsis. So, we have talked about the signs and symptoms. Now, what are the criteria? It is called SIRS criteria, sepsis inflammatory response syndrome. You have to know the SIRS criteria for diagnosing or suspecting sepsis. That means body temperature, if you talk in Fahrenheit, more than 100.4 degree Fahrenheit or less than 96, heart rate more than 90, respiratory rate more than 20, and white blood cell counts more than 12,000. In few books, it is written 15,000. You may take any. You can make your own protocol. So when any of these two criterias are positive, you suspect sepsis. Sepsis suspect, that means what? That you have to rule out now the septic focus because you have already suspected sepsis. So next step is you have to rule out the septic focus. And if it is present, then the diagnosis becomes sepsis. Here your diagnosis was SIRS positive. Now once you have identified the focus, then diagnosis becomes sepsis. Now you have to rule out whether it is severe sepsis or what type of sepsis. And if the patient's BP is not being maintained even after giving adequate fluid replacement, then the diagnosis is septic shock. And you will be shocked to know that when we diagnose a patient in septic shock, the mortality rate is already more than 40%. That means we have to diagnose the patient in this stage. So very simple picture, maternal infection plus organ dysfunction means maternal sepsis. Now, what are the organs which can be damaged by sepsis? Central nervous system, cardiovascular system. In pulmonary system, we have ARDS, that is called pulmonary edema. This is infective pulmonary edema. And there is another pulmonary edema, which is called because of hypervolemia, that is cardiac pulmonary edema. Then we can have paralytic ileus, hepatic failure, increased transaminases. Kidney may have a total failure, oliguria and acute kidney injury. Then in a hematological system, we may have DIC. Patient may die of DIC also. And adrenal dysfunction is less commonly seen. I've seen all these complications in my own hospital. Only endocrine system complications are less. So I'm again showing you the SIRS criteria, and I will be showing it again also because our main focus is on SIRS criteria. Now, along with SIRS criteria, I've written here two more criteria, Q-SOFA and OMQ SOFA. Q-SOFA means quick SOFA score, which is a bedside method, and OMQ means obstetrically modified, because you know that in pregnancy, because of the physiological changes, the respiratory rate is already more than the normal non-pregnant women. The BP is considered, threshold is considered little low. That's why. Now the thing is that once we had taken, I'm just sharing one example. We had attended a whole day program on sepsis somewhere. We ourselves had organized. And then later on, the feedback, they asked us about the feedback, what did we learn and what we have done in our respective hospitals. Someone has responded, ma'am, we have advised our residents to do SOFA score as soon as the patient arrives to emergency. And they have made it mandatory to write SOFA score in every case sheet. And they said that this way they are controlling maternal sepsis. Why did I mention this example? Because I do not agree with this. See, when the patient reaches this stage, when we are assessing Q-SOFA score, her mental status is already altered. I do not want my patient to go into this situation. I would like to diagnose sepsis in this stage. So I think I am clear to give this message that we have to focus on search criteria and clinical signs and symptoms, and this is a late phenomenon. So when we suspect sepsis, now our 1 hour bundle starts. Previously, about 5-6 years back, it used to be called 6 hour sepsis bundle, and later it was reduced to 1 hour sepsis bundle. So in this 1 hour, we have to take blood culture, we have to give antibiotic, we have to advise lactate, and if the patient's BP is not maintained, then we have to give vasopressors. We may have to advise investigations to diagnose the cause of sepsis, like few imaging study and cultures. Then we have to find out the source of infection. If it is choriamnitis, then we have to deliver the patient. If it is return product of conception, we have to remove that. And if the baby is inside due to choriamnitis, then we have to do electronic fetal monitoring also. And in some cases, high risk cases, we have to give DVT prophylaxis. So the most difficult aspect of recognition of SIRS in pregnancy is the differentiation of the condition from the normal physiological changes of pregnancy with which it overlaps. When I take round of my PNC wards, I just pick up sepsis patient based on these criteria and take them to SDU, high dependence unit. So again, I'm reiterating that Q-SOFA score does not define sepsis. Rather, it is a rapid method of identifying those patients at high risk of developing severe complications who require more aggressive therapy. मेरे को अपना पेशेंट इतने सीवियर कंडीशन में नहीं पहचानना है, मेरे को अपना पेशेंट उस समय पहचानना है जब वो SARS पॉजिटिव है and the patient has not reached yet to the assessment of altered mental status or SOFA. So in initial 1 hour, if the shock is not present within 3 hours of suspected diagnosis, we take culture, give broad spectrum antibiotic, and we start 1 to 2 liters of crystalloids in the first 3 hours, or 30 ml per kg of body weight. पूरे वर्ल्ड में ये एक ही है 30 ml per kg of body weight, or 1 to 2 liters in the first 3 hours. So you just please remember this. And even after this, if the patient's BP, mean arterial pressure, is less than 65, then we have to give vasopressors. पूरे वर्ल्ड में the only one vasopressor of choice is norepinephrine. It is norepinephrine and norepinephrine. Second is vasopressin. Then you start at a dose of 0.25 microgram, and in severe sepsis you can add on with hydrocortisone. And we have to avoid hyperglycemia. It's a beautiful pictorial format. What to do? See, this is 1 hour bundle. You have suspected sepsis because 2 of the criteria of SIRS criteria were positive. Now what to do? Measure lactate level. Once, madam, I was discussing the case of maternal sepsis with ma'am, Sharda ma'am. Ma'am को मैंने एक बात बताई थी, ma'am. At many facilities, lactate levels are not done. Even in my facility, at many places, lactate levels are not done or they are not readily available. Forget about this. आपने SIRS criteria positive देखा, and then you start antibiotic, you give IV fluid. If BP is not maintained, you start norepinephrine and find out the focus of sepsis. Lactate criteria will not cause much change in your initial management of sepsis. और जब तक आप इतना मैनेजमेंट कर देंगे, एंटीबायोटिक दे देंगे, IV फ्लूइड दे देंगे, इमेजिंग या कुछ इन्वेस्टिगेशन कराएंगे, by that time your lactate level will arrive or you will get another opportunity to ask for a lactate level. So beautiful picture. Blood culture bottle and then IV antibiotic, then rapid fluid 30 ml per kg, and then vasopressors if mean arterial pressure is less than 65. और ये condition यदि होती है mean arterial pressure less than 65, even after fluid, then we call it septic shock. I have already told you the maternal mortality in this condition is more than 40%. We in DDU are using a 10 minutes bundle. It is my standing order to all my residents that once you find SIRS criteria positive, you take only 10 minutes, not even 1 hour. ब्लड कल्चर की बोतल आपके पास रेडी होनी चाहिए, एनी टाइम अवेलेबल होनी चाहिए. एक साइड में ब्लड कल्चर बोतल रखिए, दूसरे हाथ के साइड में आप एंटीबायोटिक रखिए. You draw blood for blood culture, put it in the blood culture bottle, and at the same time, another person, please be ready and give antibiotic. Why? If you remember this line very carefully, if antibiotic treatment is delayed, then mortality increases by 7% with each hour delay. यदि मैंने 5 घंटे देर कर दी after getting the patient SARS positive, then I've increased her mortality by 35%. So it is very important to give antibiotic as early as possible. So we are almost following 10 to 20 minutes bundle in our hospital. Now stage 2, you find out such criteria, you have given fluid, you have given antibiotic of stage 2. You have to find out whether there is any organ damage, because we already discussed that some organ damage may occur in sepsis. So organ damage, respiratory, cardiovascular, liver, sari hoegi. So you get those investigations done. For liver, you get blood gas analysis. Coagulation profile, you've sent thrombocytopenia, you've sent platelets count, and get PTNR done. Cardiovascular, you have to measure her BP, and you can get an ECG done. Then for renal, you get a urea or creatinine, and mental stress is just a clinical assessment. And lactate, usually in ABC machine, your lactic acid level is available. These are the investigations: CBC, peripheral blood smear, LFT, KFT, which we send in our hospital. And but just one thing I would like to add, that sometimes I always advise peripheral blood smear, because sometimes we get toxic granules, and that is very much suggestive of sepsis. And always monitor with these. This is again a gist, so those who are interested can take a screenshot. Here I just wanted, why did I want to put this particular slide, is that there is another group, California Maternal Quality Collaborative Center. They say that WBC limit is 15,000. It doesn't matter whether you take 4 to 12,000 or 4 to 15,000, because many books say that in pregnancy even 15,000 is normal. But the thing is that you have to correlate with other signs. If the patient is having these two criteria positive, but her WBC is 12,000, but she is having high temperature, then please become conscious. That's why I wanted to put this slide. And now the question comes, where is the sepsis? Because the treatment for sepsis is not complete with IV fluids and broad spectrum antibiotic. You have to find out the cause of sepsis, and you have to remove that focus. Pus anywhere that needs to be drained. So you start from head to foot. I have already mentioned that the commonest cause is genitourinary region. So you first rule out genitourinary cause. And if still you are not able to find the focus, then please from head to toe, you try to examine the patient, rule out breast abscess. Choriomatis will be obvious. Rule out septic abortion. You know, nowadays many women are coming with sepsis. They have taken empty pill at home, over the counter, at 2 months amenorrhea, 3 months amenorrhea, and keeping on bleeding and coming to us in sepsis. We have saved many patients in the last couple of months. Then infected wound. Malaria is a very important cause in our countries. In fact, every month we get one patient of sepsis because of malaria. Meningitis is rare nowadays. Respiratory infections are very common. Toxic shock syndrome has reduced. UTI is very common, and there can be a non-specific feature also. So you are examining the patient from head to toe. SOFA score, just take a view of the picture. I am not discussing it. It is too complicated, sequential SOFA score, and I really say that we really do not require much of this. We can manage sepsis by remembering the search criteria. This can be only tested in the designated area. So the indications for transfer to ICU: cardiovascular if the patient is having hypotension and requires vasopressors; respiratory if she is having pulmonary edema, that is the infective pulmonary edema, ARDS it is called. Patient requires mechanical ventilation or airway protection. Renal if she requires dialysis, her creatinine has risen a lot. Neurological if she has decreased conscious level. Another multi-organ failure, we call it MORS, uncorrected acidosis or hypothermia. Now these are the now the question arises, what are those antibiotics which we were supposed to give when took culture of blood and we wanted to give the antibiotics? So if we have a leading point, pneumonia, then we can give these antibiotics. Hospital acquired pneumonia, then we have to shift to these, ceftriaxone and imipenems. Choriamnitis, MP plus Zenta is good enough. Nowadays, Zenta has come into little disrepute because it was seen that it causes some kidney problem. Then endomyometritis, we give Clinda. Clinda is very good along with ceftriaxone or ampicillin. Then UTI, ampicillin is good. We can also add nitrofurantoin. And for soft skin and soft tissues, we give Vanco plus Piptaz. This suggestion given by Society for Maternal Fetal Medicine 2023, the latest literature on maternal sepsis. Just I want to give a little picture of few commonly used antibiotics. If we use co-amoxiclav, then it does not cover MRSA, but it covers Pseudomonas. Then metronidazole only covers anaerobe. So you have to always add some antibiotic with metronidazole. But if we replace metronidazole with clindamycin in few cases, then it will cover both the anaerobe and the MRSA. So it is always better. So we have to take care of the situation that when we have to replace metronidazole with clindamycin. Then peptide is a very good broad spectrum antibiotic, and we are using a lot of peptides in our hospitals. If the patient does not respond in 24 to 48 hours with peptides, then we add meropenem and clinga. It covers almost all organisms except MRSA. So you can add clinda for MRSA, or you can add meropenem. And vancomycin is a very good drug for MRSA. So few words about chorioamnitis, because it is a cause of during pregnancy maternal sepsis. We get more sepsis in the postpartum period or post-abortal period. So it may lead to bacteremia, hemorrhage, and death. And the MRSA may be resistant to clinda. So in that case, you will add vancomycin and teicoplanin. MRSA is a very common problem in obstetric cases. Now we have found out the focus of sepsis also. Now what next? Evacuation of retained products of conception, if they are the cause for sepsis. Debridement of wound infection, if that is the cause. Percutaneous drainage of abscesses, if they are the cause. Percutaneous nephrostomy, if that is the cause. Delivery of the fetus, if chorioamnitis is present. Any type of conservative management is contraindicated once chorioamnitis has set in. And hysterectomy for myometrial necrosis. I would add this 2-3 examples on this case. Till in my life, in last 22 years, I operated on 4 patients who had myometrial necrosis. When I was doing surgery on these cases, whenever I used to prick needle in the near the uterus or in the uterine myometrium, pus was coming out. So immediately it strikes to my mind that I have to remove this uterus, unless otherwise, in spite of draining the pus and in spite of giving the highest antibiotic, I will not be able to save the patient. And all the 4 patients survived. If the sepsis develops during pregnancy, then it is not an immediate indication for delivery unless it is a case of chorioamnitis. So we have to individualize the case. Delivery should be reserved for the usual obstetric indication after stabilization of the women. And there is no evidence that delivery improves maternal outcomes. In most cases, resuscitation that improves maternal hemodynamics will result in improved uteroplacental perfusion and therefore improved fetal condition. If the uterus is found to be the source of infection, delivery is indicated, and involvement of neonatology, anesthesiology, and critical care consultants is fundamental. At one stage, when it becomes complicated, it requires a multidisciplinary approach. CTG monitoring is required during pregnancy, and epidural and spinal anesthesia should be avoided in women with sepsis, and the general anesthetic will usually be required for cesarean section. This is a very, very important point. Incidence of mortality and morbidity increases when we use epidural and spinal anesthesia. And in most cases, we give 1 to 2 liters of pistaloids. That means almost 2 to 3 bottles. And if we have to measure the response, fluid response, then we can accomplish it with pulse pressure variation or passive leg raising. In hypertensive patients who are not fluid responsive or who are not candidates for further fluid resuscitation, like women who are in pulmonary edema, vasopressor should be utilized to increase blood pressure. And the purpose of vasopressor is to constrict pathologically dilated systemic circulation and maintain adequate perfusion. Now I'll give you little knowledge about vasopressors. Norepinephrine is the first line agent. It has been studied in human pregnancy and is often used to maintain blood pressure with regional anesthesia at the time of cesarean delivery. And acknowledging the lack of high quality evidence in the setting of pregnancy associated septic shock, norepinephrine appears to be safe for fetus, especially at low doses. So these are the common vasopressors. You can take a screenshot of this. Norepinephrine is the choice undoubtedly, and first line agent in septic shock, and second is vasopressin. Then comes epinephrine and dobutamine. We are commonly using norepinephrine, vasopressin, and dobutamine. So regarding vasoactive part of management, we are using norepinephrine as first line. Our target is to make the mean arterial pressure more than 65, and we consider invasive monitoring of arterial blood pressure this time, and we consider initiating vasopressors peripherally. And if still mean arterial pressure is inadequate despite low to moderate dose of norepinephrine, then we consider giving vasopressin. So now you know that we have to start with norepinephrine and when to add vasopressin. If cardiac dysfunction with persistent hypoperfusion is present despite adequate volume status and blood pressure, then consider adding dobutamine or switching to epinephrine. And universally, this is followed. Now, suppose a maternal sepsis has occurred in ward. So I'm just sharing a call-out algorithm in surgical wards. Early morning score 4 or more, you can monitor through SIRS. Alert surgical team, senior nurse, clinical skill educator, do ABCD, view charts and notes, implement oxygen therapy, give IV access, fluid, reassess, and then refer to critical care team. Now, till now we were talking a lot about peptides, meropenem, Clinda. So let's have this chart I myself made after searching through many literatures, and it's a ready to use beautiful chart. You know, when we prescribe in ICU, there's somebody asking, what is the dose in renal case? Her kidney function is deteriorated. What is the usual dose? So remember that the standard dose of peptides is 4 to 5 grams, 6 hourly in sepsis. And the renal dose is 2.5 grams. Route is always IV after skin test, and the spectrum is very broad. Meropenem is the second line of drug when your patient is not responding to peptides in 36 to 48 hours. The dose is 1 gram if the patient is more than 50 kg of weight, and this is 500 milligram is less than 50 kg, and the spectrum is very broad. The route is IV. Now onwards, whenever you go to ICU and treat a sepsis patient, now you know everything. You have a good knowledge of antibiotics. Vancomycin, the dose is 1 gram IV. Spectrum is narrow, but one beautiful coverage of MRSA. And I've seen in my experience that in many cases where we have added vancomycin, when the patient did not respond to Meru-Clinda, then this caused miracle, vancomycin, and many lives were saved. Then Clinda, the dose is 600 to 900 milligram, 8 hourly, and the spectrum is narrow. It covers anaerobes very well, and a few MRSA. Teicoplanin comes after all these antibiotics have failed. Then we give a low escalated on day 4. These are my own pictures. When we sit here to give some presentations, so then we have to provide the full knowledge about everything. So these pictures I've taken from my own camera in my own ICU. So this is peptides, and I request everyone to see the bottle, look at the preparations, how much is the composition and what are the indications and contraindications. This is meropenem, 1 gram, 500 milligram both. This is vancomycin. It is the hydrochloride salt which is used, clindamycin and teicoplanin. ये पिक्चर ही आपको बता देगा बार बार कि these are the common antibiotics which are being used for maternal sepsis patient. One important line, intravenous immunoglobulin is recommended for severe invasive streptococcal staphylococcal infection if other therapies have failed. हमारे लिए रिसर्च स्टेज में कुछ नहीं है. So अब क्वेश्चन आएगा कि हमने ट्रीट कर लिया सेप्सिस को. नाउ द क्वेश्चन कम्स, हाउ टू प्रिवेंट. ट्रीट हमने करा सर्स पॉजिटिव देखकर, अब हम प्रिवेंट कैसे करेंगे उसके बारे में बात करते हैं. So we know that these are the conditions which lead to increase of sepsis. Any procedure, any amniocentesis, suture, prolonged rupture of membrane, very common cause, prolonged labor. तो ये सब हमको avoid भी करना है. Vaginal trauma, episiotomy, cesarean section, RPOCs, obesity is an independent factor, diabetes, anemia, immunosuppression, socioeconomic deprivation, pelvic inflammatory disease. So we have to be more careful, and we should cover these procedures with antibiotics. We should avoid prolonged labor. We should avoid PROM also. and try to intervene as fast as possible in problem. WHO says these are the 5 moments of hand hygiene that we should practice diligently and honestly in every case. Hand wash before touching the patient, before clean aseptic procedure, after touching a patient, after touching patient surroundings also, and after body fluid exposure risk. ये हर जगह डिस्प्ले होना चाहिए ये पोस्टर हमारे वार्ड्स में, लेबर रूम में, ओटी में. बिफोर टचिंग, बिफोर क्लीन एसेप्टिक प्रोसीजर, आफ्टर बॉडी फ्लूइड. मैं रिपीट कर रही हूँ बिकॉज ये हमें रटा हुआ होना चाहिए. आफ्टर टचिंग ए पेशेंट, आफ्टर टचिंग पेशेंट सराउंडिंग्स. It will contribute to patient safety and will save lives. Antibiotic prophylaxis कहाँ देना है? In first trimester and second trimester abortion we have to give for these procedures. Then first and second stage of labor में we have to give GBS prophylaxis. Then third stage of labor में with manual removal of placenta and third and fourth degree tear. Routine episiotomy में आपको antibiotic नहीं routinely देनी है. Normal second और third stage labor में नहीं देना है. If patient is having prom, then you will give. And during cesarean section, it is mandatory to give antibiotic prophylaxis. And I will tell you what antibiotic we have to give. WHO recommendation on prophylactic antibiotics of women undergoing cesarean section. WHO says, 2021 literature, single dose of first generation cephalosporin or penicillin should be used in preference to other classes of antibiotics. So we have cefazolin as a first generation cephalosporin. We can use that. We can also use ampicillin because it is a penicillin. But please don't use third generation cephalosporin, which is ceftriaxone, cefotaxime. Many hospitals are using this. And the guideline says that we have to, that for cesarean section, prophylactic antibiotics are recommended for women undergoing elective or emergency section and should be given 30 to 60 minutes prior to skin incision rather than intraoperatively after umbilical cord clamping, consistent with recommendation of 2015. And one important point I would like to highlight that we should not use amoxi plus clavulanate combination before cord clamping because it causes necrotizing enterocolitis. In fact, we are not using it in antenatal period also. This brief view of first generation cephalosporin, cefazolin. So your prophylaxis drug is this, and very commonly ceftriaxone is being used. We should not use this. You can take a picture of this overview of drugs also. So the recommendation, last coming to the recommendation for prevention of sepsis, WHO says that septic shock should be considered a medical emergency and treatment and resuscitation for sepsis begin immediately. And providers consider the diagnosis of sepsis in pregnant women with otherwise unexplained end organ damage in the presence of an infectious process. Regardless of the presence of fever, we do not require fever always. And they recommend giving empiric broad spectrum antibiotic, ideally within 1 hour, in any pregnant women in whom sepsis is suspected. They recommend culture, blood, urine, respiratory, others, serum lactate levels, and early source control. Then IV fluids, crystalloids, 1 to 2 liters. Then use of norepinephrine if BP is not maintained. And they recommend against immediate delivery for sole indication of sepsis. And the delivery should be dictated by obstetric indications. The Societies for Maternal and Fetal Medicine in 2023 puts emphasis on the same part. I'll just go through this or take a picture, almost same. Out of this is best practice. Sepsis and septic shock in pregnancy be considered medical emergency and treatment and resuscitation should begin immediately. Obtaining tests to evaluate for infectious and non-infectious causes of life-threatening organ dysfunction in pregnant and postpartum patients with possible sepsis. And they recommend an evaluation for infectious causes in pregnant or postpartum patients in whom sepsis is suspected or identified that include microbiological cultures, blood culture before starting antimicrobial therapy, as long as there are no substantial delays in starting antibiotics. And after a diagnosis of sepsis in pregnancy is made, they recommend rapid identification or exclusion of an anatomic source of infection and emergency source control when indicated. They suggest insulin therapy when blood glucose level is more than 180, DVT prophylaxis in high-risk cases, and because of an increased risk of physical, cognitive, and emotional problems in survivors of sepsis and septic shock, they recommend ongoing comprehensive support for pregnant and postpartum sepsis survivors and their families. And they recommend against the use of starches or gelatin for resuscitation in pregnant and postpartum patients with sepsis and sepsis shock. Here I would like to say that please stop using any type of gelatin, any type of hexa starch in a management of a postpartum patient, neither in PPH nor in sepsis. Just use IV fluids. Crystalloids are the fluids of choice. They suggest corticosteroids. So this is the whole gist. So this is the picture. You are starting when organ dysfunction is seen, then organ dysfunction, hemodynamic support, respiratory support. This is WHO model, and the Global Maternal and Neonatal Sepsis Initiative is to contribute to sustainable development of goals by developing solutions to reduce maternal and neonatal death related to sepsis. And the goal is to accelerate the reduction of preventable maternal and neonatal death related to sepsis. Objective is to raise awareness among the care providers and assess the burden and management of maternal and neonatal sepsis at the global scale, develop and test effective strategies to prevent, to detect and successfully manage maternal and neonatal sepsis. And our priority areas of work should be on strengthening the health program, research and development, innovations, and global advocacy. This same chart I'm showing again, and it only needs to be pasted. So now we have no fear for maternal sepsis because we know how to suspect this before making a complete diagnosis. And every year, Maternal Sepsis Week is observed in the week of Mother's Day. And in 2025, it will be held from May 11 to May 17. And we will do a major work during this time for our DGF if with everybody's consent next year. And please join Sepsis Alliance in raising awareness of maternal sepsis to save mothers and birthing people. Thank you.